Can you, oh, yay! Can you hear me now? Hello? Awesome. Okay. Okay. Wonderful. Yes. All righty. Okay. So, I'll start again. Like I said, it's a new software, so I do apologize. I'm trying it out tonight, and hopefully it'll work out. So yay! Hi everybody! Happy New Year! And like I was saying before, nobody could hear anything. Um, Happy New Year. This is a wonderful year. It's an opportunity, is the promise of a new year, an opportunity to redefine ourselves, to find a new path, to create new adventures. Okay, so everybody, just you know, be positive. Let's start on a great foot. At the office, we're all like, getting into the detox mode, and the way you start things is always very important. That's why a lot of the greatest philosophers talk about those first 5-10 minutes of the day will put the tone for the rest. So let's all get in the right mindset, and this is going to be your year. It's going to be mine for sure. I have already declared and claimed it. All right. Very good. So tonight I want to talk about the different challenges that keep bobbing through the fertility journey. Okay. There's certain recurrent issues. And like I was saying, earlier, and you guys can hear me, but I wanted to kind of open up with that, some sort of troubleshooting. One of the challenges that I get is the travel patients. Okay, and I've discussed this before, but I think that it never gets old. So what to do to make the travel experience better? So what are the travel patients? A travel patient is somebody that does not live in the vicinity of any of the CNY fertility locations, or it's not going to come in and monitor in any of the CNY fertility locations. So it's going to do monitoring from where they live, and it's coming in to one of our facilities for retrievals or transfers. So in general, this is how the journey goes. I tell people that first you have the discovery phase, and that's pretty standard no matter where you're going to do your fertility treatment. So that is your semen analysis, your blood work, your hormonal panel, your prolactin, your thyroid testing, your DHEA, your FSH, your AMH, anti-Müllerian hormone, your estradiol, so your day 3 labs, all of that information to better assess what's happening, semen analysis for the boys. So that's kind of the discovery phase. And you can do that from home, okay? A lot of times, some of you request the orders before, but usually on that first visit with your provider, the order gets placed in, you print it out from the portal, and just take it to LabCorp request or hospital lab to get your labs on the 3rd day of your period. A lot of larger labs and hospitals will do semen analysis. That's another big question that I get. And the hysterosalpingogram or the dye test with the saline ultrasound can be done usually with an OBGYN and certain radiology locations. We can definitely place the orders for you to get that information, because that's going to give us a lot of information also to help you find that solution we're all seeking. And then when you're actually going to start with your treatment, then generally we go with the first day of the period. Okay, at that time you would call CNY and you will let them know, okay, I'm ready to start. I have my medication. That's very, very important. I get people show up in the office, they want to start their IVF and they have nothing. All right, no, you have to have your medication. you know, ready to go, because it's like, boom, we start. Once the NY gives you your start day, then you're going to get your baseline ultrasound and blood work. And that same day, you're going to start your medication, your injections, okay? 4 to 5 days later, ultrasound, blood work, and then every other day until the eggs are ready for retrieval. So that is a 10, 12-day window, and that you can do from home. Now, this is when it gets tricky, because you are getting monitored on an outside facility. So you need to be a little bit more proactive, make sure that the results get sent over, somebody looks at them. So you might have to call you know, CNY and the travel team and say, did you get my labs? Did the provider look at them? What's the next step? Okay, so that's very important. You need to be a little bit more proactive. You can always call the clinic that you're going to and try to create a relationship with the nurses directly. I tell that to my patients in Atlanta, and the office in Atlanta, the phone number is 770-266 3930. Okay, so you can always do that, and that, you know, makes it a little easier. Okay, another question that I get is how long is the whole process? So this process from beginning to transfer, if you do a fresh transfer, is about 3 weeks. So it mimics what a normal cycle does. If you go back to your biology from high school, brush it up there. So you get your period, and about 2 weeks later you ovulate, and then you know, it's the 2-week wait to see if you're pregnant, and the period comes in 28 days. So we do kind of like the same thing, except we give you all of this medication to hyperovulate you. Usually retrieval is about day 13. And then you get the transfer 3 to 5 days later, and you still have that same waiting period. So the longest that you're in New York is about a week. So somewhere between 2 days to 7 days if you want to have a fresh transfer, or it's okay to have a fresh transfer. Sometimes the stars do not align and it's not convenient to do a fresh transfer. All right, so that's one of the biggest challenge, people trying to understand how the process goes and how they're going to manage the travel. Now, I also get the question, how am I going to plan all of this? Unfortunately, you will get a 2 to 3 day window of when you're going to go up to any of the CNY facilities to get your retrieval. That's pretty much it, okay? I know that some people will drive depending on the distance, but you get about 2-3 days of a window to get your tickets to fly. All right, so I hope that that was helpful. And then we'll keep talking about some of the other challenges. I know that you guys are putting a lot of questions. I always like to give time for the questions, but you know, we talk about the failed transfers. That's another big challenge. I get a lot of the follow-ups on those failed transfers and the questions of what happened. And so on the failed transfers, we have to verify, you know, if the hormones were okay, if the receptivity, okay. If you have one failed transfer, it's kind of a, you know, see the whole picture, but occasionally it's worth doing the ERA early on to make sure that the amount of progesterone you're getting, it's adequate in terms of exposure to the endometrium in order to receive the embryo. Are we dealing with infection? That's another big one. Any active endometriosis, adenomyosis, anything that could be interfering with the adherence of the embryo. And what else can we do in terms of add-ons? Did you do an ACG wash? How about a PRP wash? I mean, I am a PRP sucker. I love it. I use it in different areas of the body. I've used PRP for over 10 years, and it's definitely something that I promote. Platelet-Rich Plasma. And, you know, acupuncture before and after also helps with creating more circulation and chi, like energy to the area to improve adherence of the embryo. Embryo glue now is standard for everybody. So that's actually great. So that's another of the big challenges. So recap, challenge number one for today was, the travel patient and what to do, what to expect. Very, very common, since 60 to 70% of all of our patients are travel. And the other big one that I know is very frustrating for some of you is the failed transfers. And I see some of you guys, I am so excited. I have been going up to Syracuse on and off, and I see some of the ladies that have shared their beautiful journey with me that are pregnant. So congratulations. We all love you so much, and we celebrate each one of your victories just with you. So I feel I love getting people pregnant. And so which I can say that being a woman, that sounds funny. I mean, maybe not so funny to somebody else, but I just feel like each baby, it's like, it's a baby, it's my baby. So it feels pretty exciting. So I see Marinez, congratulations. May you be super, super, super blessed, and your new baby coming up. I see a few questions that I want to address. The price of monitor increased a little bit. I don't know the details, but I know it went up $100 or $200, something like that. We are still very proud to be the most affordable on the nation. I am very proud of being part of that to help you guys. I have another question. What happens if those days fall on a Saturday or Sunday? Most clinics will open on a Saturday, so you'll be able to cover that. And we haven't had any issues kind of going around Sundays, okay? We do program things to be able to have Sunday off for everybody. I wish there was someone else as the middle person instead of us as patients. It can be very stressful to be your own liaison. Yes, and that's why, Miss Nelly, I'm being so open about it. It is not the ideal. It's nothing is perfect, right? It's not an ideal system, but it is the best that we can do to help people that can't be with us for 2.5 weeks or so. And that's why I'm giving you all these tricks to make the experience the best possible. So there's nothing like a personal relationship. So the patients that I talk to, or any of our staff in Atlanta, we just create a relationship. So you can always do the same thing with the facility you're going to. Let's say you create a relationship with Syracuse and you get to know those nurses. You can call them directly, have a relationship. You can say, hey, could I speak to such and such? And then they'll get familiar with your case and it'll be a little easier. You can even do that with the travel team and say, look, I would like to talk to this or this person. I understand that everybody goes in and out and there's vacation. And so, if you create a relationship with a group of people, 2, 3 people, that also makes it easier. Okay. And then, yes, LabCorp works on Saturday and the results won't be until Monday. Yes, it is what it is. It is not ideal. Ideally, you all came to us, you monitor with us, we get your labs right there and then, we see your ultrasounds. But if you live far from us, and we work with what we have, okay? Yes, local hospitals can give us monitoring, okay? And there's sometimes local hospitals that will have a good sonographer that will feel comfortable doing GYN ultrasounds and follicular monitoring. I know that the hospital here does have a few sonographers that are magnificent, and we do have a few other groups in the area that feel comfortable doing follicular monitoring. Will you know before traveling to New York if you're eligible for a fresh? No. The final decision for a fresh will be at time of retrieval. So what are we looking for? We're looking for the labs from the retrieval day. The progesterone needs to be less than 1.5. Very important, okay? 2, how was the retrieval? Okay, was it a bloody retrieval? Did they take out a lot of eggs? Is there going to be swelling or inflammation? Those things need to be taken into consideration as well. And the lining at time of retrieval will also determine if you can do a fresh. So it's kind of a hit and miss. Okay, the stars need to align, otherwise you're going to lose the embryo. What is the time frame of a frozen transfer? Frozen transfer, it depends on the age of the embryo. If it's a day 3 embryo, then we'll get the lining. There are different ways of doing it, but essentially we get the lining to more than 7 millimeter trilaminar and then switch over to progesterone. So day 3 embryos, 3 days of progesterone, day 5 embryos, or beyond 5 days of progesterone for transfer. So that's kind of in general, a medicated FET cycle. An ovulatory cycle, either natural or electrolyte induced. We will monitor you until you ovulate. I prefer to trigger people, that way I can know for sure when you ovulate. And then 36 hours after trigger, we start the progesterone and start the counting. You are welcome. This is the reason. So Rebecca, this is the reason that we're here. I do my Facebook Lives on Tuesday about this time in English. Tomorrow will be Spanish, but we have multiple of our providers getting on this chats to help you, okay? Because I know it can be frustrating. Alrighty, so what are the benefits of fresh versus frozen? What is typical to do on a transfer with the same cycle as an egg retrieval? So a fresh transfer means that it is on the same cycle as the egg retrieval. So they take out the eggs, they fertilize them, put them in the embryology lab, let them grow and expand, and then 3 up to 5 days after the egg retrieval, they'll be putting an embryo back in, and those embryos will never be frozen, the one that, you know, gets put back in. Benefits, there's a lot of questions. Traditionally, they believe that frozen embryo transfers work better. There's actually, even if you look at the entire population, there's a slight change. You know, it's like 40% to 50% chance of success with frozen, 30% with fresh. But why is that? And that's the entire population, because then that gets different with subgroups. On the older crowd, fresh is better, although as I go into the explanation, you see that it all makes sense. On the younger crowd, like I was saying earlier, if you end up with a lot of eggs, it's not a great time to do an embryo transfer. 1, because you're going to have a lot of estrogen in your system. 2, there's going to be a lot of inflammation. The more eggs is the more holes in your ovaries, okay? A lot of internal bleeding and inflammation just from the procedure, okay? The older population tend to have less eggs, and at the same time, they're more frail. So the least amount of freezing and, you know, defrosting that you do, the better. So older crowd, really, I encourage fresh. Younger crowd, depending on the scenario. But either way, there's a lot of babies that come out of fresh. And so if the stars align, I would definitely do it. We got another baby. Yes. Yes. Awesome. 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 So Karine is pregnant with twins. May you be abundantly blessed. I am so, so happy. I'm so happy for you. I will be going up to Syracuse again soon. I've been going every month for a long time now. I took a break, a very long break, because of the COVID craziness, but pretty much I've been there every month in September. So I'll be coming up soon again. Yes, the Atlanta office, we are working really hard to get it up and running with full capacity. We just got new equipment. Today we actually had a staff meeting to try to get a better patient flow to be able to absorb growth. I am extremely proud of the girls. I think that we have an amazing team, and we're ready to expand. I've been discussing with Dr. Kill's expansion, and cross our fingers, toes, and a lot of prayer. Somewhere between March and June is it's kind of what we're aiming for. How much time it is between egg retrieval, then PGS testing. Okay, so egg retrieval, in order to do PGT testing on the embryos, they need to be 5 days and beyond. All right, that is one of the challenges that sometimes I get on older patients. Like I was saying, low variant reserve patients tend to have more frail eggs. Sometimes they don't make it to day 5. And so they need to be frozen day 3 or sacrificed. So it's kind of a tough situation to be in. And then essentially the next month you can do a frozen embryo transfer. Results from the PG testing takes 2 to 3 weeks. I like to say 3 because it's really like 2.5 to 3 weeks for the results to come back. And then that gives you time to get ready for an embryo transfer. All right. Yeah, so going back to Atlanta and its expansion, yes, probably we'll be doing frozen embryo transfers first, and then doing egg retrieval and full embryology lab later. So again, crossing our fingers, toes, everything. The earliest would be March, if the stars align, March, April, May, but we're working very diligently to be able to expand our services to serve you better. How did you establish a relationship if you don't know who your nurse is? Because you're going to talk to somebody. So again, I can only talk about the office that I run, but I'm sure, I mean, everybody at CNY loves what they're doing, and we're all here to help you. So it's a matter of creating a relationship. So you're on the phone and you can ask their name. Our patients call in, and like our nurses Nicole or Melissa or Candace or Dr. V or Martha or Kim, Jenny, financial, Lisette. So you start creating a relationship with people, and then you just ask their name and call the clinic that they're affiliated with. Or even if you call the global travel team, there's a name, even on the emails. Just request to talk to the same group of people. It's doable. I know that there's a bunch of girls that definitely call us. All right. Do you recommend PRP? Absolutely. Like I was saying before, I've used PRP for over 10 years. I actually was introduced to PRP from the cosmetic side. So if any of you know what the vampire facial is, so I started, let's see, 2011 with vampire facials, then moved into pain management and adhesions for like surgeries to sexual dysfunction, fertility, GYN. So I've used it in many areas of the body. I actually injected my mother 3 weeks ago in the knee. Okay, so I have a lot of experience and I love it. I think that it's a great concept. Essentially, it's your own healing proteins. Okay, platelet-rich plasma. It is the proteins associated with the platelets that you pretty much harvest from your own blood, so reaction is near to zero, and then you use it where you need it. Now, it's not like a quick fix. It takes a while for that reaction to maximize. So in the PRP world, you have to give it about 3 weeks, okay? So some of you that work with me for ovarian or uterine priming, I say, okay, 1 to 3 months to get your body ready to optimize the effect of the PRP. PRP done as a wash before a transfer. I like to do it up to a week before, same principle. So especially if you're going to do several different add-ons, I say ACG 24 hours before, Neupogen 48 hours before, PRP 3 to 7 days before transfer is what I prefer. I know that with the travel patients, that could be a little more complicated. But if it was in the ideal scenario, that's what I would recommend. Somebody's doing a fiber removal in February. How long after the removal can I start IVF? It really, really depends on how, where the fibroid is and if they went into the muscle of the uterus. You can definitely do IVF and do embryo banking. So you can do retrievals and just kind of pile up the embryos. We do not recommend transferring on a uterus that has, had a surgery in the muscle for 6 months to a year. ACG wash, yes. So we can do ACG wash. So ACG is the hormone of pregnancy, and sometimes we use a small amount. So we can divide it and do a booster a week after transfer, and then just use a small amount, put it in the uterus. And what it does, it kind of helps with the receptivity of the lining to the embryo. All right. Okay. You guys are hot on today. Good. This is an excellent example. So Miss Kelsey is saying she had an embryo egg retrieval yesterday with 35 eggs. That's a lot of eggs. You really want to consider that's a case that it's kind of like this for a fresh, because if you take out 35 eggs, that's a lot of inflammation in the pelvis. So things to ponder. All right. If you end up with a whole bunch of embryos, then and you put 1 or 2 in and you're lucky, it works perfect. But just keep in mind, how do you feel? How's the inflammation in the area before you make your final decision? Do I recommend an ACG wash? Yep, I would. 24 hours before, the day before. I'm a sucker for PRP, but hey, everybody's different, and I am into the throwing the kitchen sink at people. So anything that works. Okay. Boom, boom, boom. Okay, so reasons to transfer 2 versus 1. I know we are in the society that, let's go biggie. More is not always better, all right? This is a very controversial subject. I will tell you the rules of the game, and I will tell you my opinion. So the rules of the game per the American Society of Reproductive Medicine is normally tested PG embryos, 1 regardless. And then if they're not tested, under 35, we recommend 1, above 35, up to 2. All right, that's kind of rule of thumb. I think that you have to take several things into consideration. If you're putting 2, you're actually putting 2 to compete for the food and space of 1. And let's say you do get pregnant with 2, your chances of miscarriage, preterm labor, and complications in the pregnancy go up. And I've seen this happen. I've seen somebody get pregnant with twins after having to put in just to lose them at 14 or 16 weeks. So I need to play devil's advocate here. If you had a failure, if you have enough embryos that it's not a big deal, go ahead. But if you have 3 or 4 embryos, it's not Dave and Buster's, people. Give each embryo a chance, the best chance possible, because each embryo is the possibility of a pregnancy. So each embryo is like a golden token, okay? Really hard to get. I mean, I walk this path with you, and I mean, it's like the hormones and the injections and the bloating and the visits and all of the expenses. So that's my opinion, my 2 cents. Would you recommend PRP and Acg Wash for somebody who has had recurrent pregnancy loss for their first IVF cycle? So somebody with history of recurrent pregnancy loss, I really, really want to dig in before I do a transfer. I would cross all the T's, all the I's. I would look for recurrent pregnancy loss panels. Are we dealing with any chromosomal issues, any carrier, any genetic disorders that we need to address, autoimmune issues, coagulation disorders? Are we dealing with chronic infection? I think that one gets really ignored. What else can we do? So I would kind of take a step back, evaluate the case, really try to dig into all the rabbit holes, and then potentially do a very robust priming, a whole body uterine priming before jumping into a transfer. All right. Now that you bring up the emails, why can't we reply to emails? We always have to start a new message in the portal. That is just the system. We use a system called EIVF. It is not like the best ever. I used to complain quite a bit when I started, but it is the one that works the best for CNY and the needs that we have. So I do apologize about that system. Trust me, from my end, it's sometimes really hard to read as well. I prefer to get messages through Facebook. I'm very easy to find. You can Google my name, and it's me, myself, and I. So, for my patients, they just send me a text through Messenger, and it's just so much easier. It pops. If I can't answer right there and then, I can always just walk to the front desk and say, this lady needs to talk to me. It's so much easier than going into the system. And then going back to creating a relationship where you can pick up the phone and actually call 1 or 2 people that you get a rapport with and just ask them directly. It just makes it easier, I think. PRP, platelet-rich plasma. For modified natural FET, what is the best cycle day to transfer a day 5 blast? Especially considering receptivity. If the receptivity is normal, that would be 5 days of progesterone, meaning if on a natural FET, like I said, I like to trigger, meaning even if we don't do letrozole, we just monitor you. I like to trigger because then from trigger to ovulation is 36 hours. You start the injections, count 5 days, and then transfer. I'm just waiting for my period to do my first transfer. When I get my period, do I do the transfer right away? No, you get your period, then we're going to, if you do a medicated cycle, we'll bring you in, do baseline, give you estrogen, get the lining to where we want it. And then it takes about 10 days or, sometimes a little faster. And then we switch over to progesterone, and depending on the age of the embryo, that's the days of progesterones that you get. And then somebody up here, I don't mean to ignore you guys, says, is 47 too old? No, spring chicken. The 40s are the new 30s. So age is complicated these days. I don't, just based on age, I cannot say anybody yay or nay. Yesterday I had a situation on a 30-year-old that was in menopause. And then you can have a 45, 46, even 47-year-old have great reserve and using their own eggs. So it really depends on what your scenario is and what is your goal, because then that is just talking about your own eggs, and then once we go into donor eggs, then it's almost like the sky is the limit. Okay. All right, my friends, it's time to go to sleep. Well, thank you so much for being with me tonight. I hope that that it was helpful, and I'll see you guys next week. And then whoever sees me tomorrow in Spanish, I'll see you guys tomorrow. May you all be very, very blessed. And remember, 2021 is your year, so you have to claim it, believe it, and it'll happen. All right? Bye-bye.